Good morning, good afternoon, and good evening, everybody. Thank you for joining us today. My name is Shannon. I'm the Clinical Application Specialist for Cercare located in Dallas, Texas. Thank you, everybody, for joining us today. A quick few things to start off with. Mics are muted and cameras are off throughout the webinar. We're going to keep them that way so everything runs nice and smoothly. We will have Q&A at the end, so drop your questions in the chat as we go, and we will work through them at the end. Don't forget, all of our previous webinars are up on the Cercare Medical YouTube channel, so if you want to catch up on anything that you have missed, you can find them there. Next week, we do have another webinar with Professor Sebastian Swaz. He'll be talking about perfusion imaging in the angio, but today we have the wonderful Professor Leif Østergaard. He is no stranger to Cercare Medical. This is his second webinar that we've done this year with him. He is one of the world's leading experts in cerebral perfusion and how blood flow at the microvascular level affects the brain in both healthy brains and diseased brains. His work is genuinely foundational to what we do at Cercare Medical, and it's always a treat to have him with us. Today, he's going to be doing a dive into neuro-oncology. So with that, Professor Østergaard, over to you.
Thank you so much. And it's nice to see so many have been able to join. So I will be talking about using perfusion imaging in tumors today. And I will just start with my disclosures. It goes now. So I'm going to be talking about the tumor biology, essentially about tumor angiogenesis and why angiogenesis and the oxygenation of tumors is important, and then walk you through what it is that the new perfusion imaging tools that we will be talking about, what they can provide in terms of information about that. And then I will take some dives into how this becomes important in the diagnosis, but particularly in the treatment of tumors. And then there'll be a Q&A in the end, as you heard just before. So first of all, tumor hypoxia and tumor angiogenesis are really key to tumor biology. So when a tumor starts to grow, as you see in the left here, when there's only like a few hundred tumor cells, they begin to spend so much oxygen and so much energy that they create hypoxia. And because of that, the tissue around them will be stimulated with hypoxia-inducible factor to create new vessels. So this is essentially a physiological system that the tumor cells hijacks to create new blood vessels that can support their growth. The problem being that often in tumors, these blood vessels are abnormal, as you can maybe get a sense of here and in the figure on the right. One thing is that they are often leaky, so they lack the normal integrity of microvessels, causing edema and leakage of plasma proteins into the tissue. But what we'll be seeing today is also that they actually may create even worse hypoxia, and hypoxia in turn, and as you'll see, also acts as a stimulant to further tumor growth. So please notice this sort of visual cycle. We'll return to that. And the last part, namely, why does this hypoxia cause tumors to grow? So hypoxic tumor parts tend to be more aggressive than the rest of the tumor. It also stimulates the tumor to metastasize, so it's kind of a adaptation, if you will, for the tumor to survive. And hypoxic tumor parts also responds more poorly or less to the therapies we have, radiotherapy, chemotherapy, and immunotherapy. So that means that hypoxia is really important in terms of the success of our treatment. It's also the hypoxic tumor parts that tends to recur after treatment, and overall hypoxic tumors have a worse prognosis than less hypoxic tumors. So notice how hypoxia in this circle with angiogenesis is really critical to tumor biology. So in classical perfusion imaging, so essentially what you're already using now, we will use dynamic susceptibility contrast, so perfusion MRI to address various parts of tumor oxygenation. The most important one being blood volume. So the blood volume tells us how much blood is in each part of the brain. And as you see over here, angiogenesis, so the formation of the new blood vessels you saw just before, that causes the blood volume to increase, and diagnostically that can be very useful. So you can see the extent of angiogenesis, in this case in a glioblastoma or astrocytoma patient that you see over here. Of course, oxygenation also depends on blood flow, so the local blood supply, and the mean transit time. We'll come back to that, but the mean transit time determines how long blood spends in the microcirculation in the tissue or in the tumor, and how much time it has to give off oxygen. So these are the parameters that we had available with classical perfusion imaging. There is one missing parameter in that, however, and that is blood's microscopic distribution. And I made this figure just to illustrate that if blood is homogeneously distributed across the tissue capillaries, then all of the capillaries have, the longest possible time to have their oxygen extracted. So you can see the color code here. Blood is more deoxygenated when it leaves the microcirculation than in this case, where the same blood flow is distributed in a more heterogeneous manner, so that along some capillaries, there'll be very short transit times, very high blood flow that allows very little oxygen to be extracted. And you can see on the color here that if capillary transit times or flows are very heterogeneous, then oxygen extraction is actually poorer. So that's what I told you about the mean transit time that we looked up before. But what's new about the this index, the capillary transit time heterogeneity, is that it captures this heterogeneity as a standard deviation of transit times, which holds information about oxygen extraction according to a model that Sune Jespersen here developed. So just to summarize the next generation perfusion parameters, the classical ones are the ones I showed here: blood flow, blood volume, the density of blood vessels, and then the mean transit time. The new perfusion parameters, so the one we're going to be talking about today, they include this transit time heterogeneity and parameters that sort of divides that transit time heterogeneity with the mean transit time that we already know. I will not be using that so much today, but it also tells about whether it's a normal vasculature we'll be looking at. And then importantly, this model that you showed before allows us to translate all of these many parameters into just one measurement, namely, what is the capacity with this blood flow, this transit time, and transit time heterogeneity? What is the oxygenation that provides to the tissue? I just noted here that this is a biophysical prediction. We don't measure actual oxygen with perfusion MRI. So back to this heterogeneity issue. So in tumor biology, people have talked about this shunt problem for many years, namely that normal vasculature has a way of always distributing blood along individual capillaries in the right way so that cells, no matter where they are, get access to lots of oxygen or the right amount of oxygen. But because of this visual cycle you saw before, the tumor builds these new vessels, of which some of them may simply shunt oxygenated blood through the tumor as indicated here. And because these microvessels are so abnormal, then the tumor microvascularization tends to create hypoxia in many places. So notice that this is separate. You can see this tumor, I try to indicate that that has a higher blood volume, but just knowing the higher blood volume tells us that there are more microvessels, but not how blood is distributed and whether this dangerous shunt problem exists as indicated here. That is what we can measure with this extra parameter, the CTH. And let me just show you here what these images look like. So here's the CTH, and in this case, it's astrocytoma. You can see the edema here. You can see a contrast-enhanced T1 here, and see that there's a little going on in this case, in this tumor. Down here, you see a more glioblastoma, a more aggressive tumor. Notice here how the CBV was increased in this one, but there didn't appear to be any sort of changes of this microvascular distribution of blood flow inside the tumor. You see how there's much higher increase in cerebral blood volume in this more aggressive tumor. And you can see how these disordered capillary flows, you can see how they seem to exist in the edema around this one. And we don't know whether that's because capillaries become compressed by the edema or whether it's the tumor starting to grow. But notice how it tells us a lot about this shunt problem in this case. And I just want to pinpoint that. So the method I showed you before, the one that measures CTH, was developed by Kim Morrison and published back in 2014. And the ones that we can all use now also has a built-in capacity to correct for leakage. So essentially make it possible for us to determine these parameters, even though there's leakage in the tumor, which as you all know, can disturb perfusion images. And what you can see up here is how did patients with glioma, in this case, how long did they survive? So this is a Kaplan-Meier plot where you see the overall survival. So how many days did the patients survive? And you can see how people with low CBV, so low angiogenesis, they survive longer than those with a lot of angiogenesis. And remember that CTH is a different sort of information that tells us how disturbed is that or chaotic is the tumor microcirculation. You can see here how that is also predictive of very poor survival in these. And over here, the edema, so these edema measurements you saw before, I factored in as well. So these were sort of the hemodynamics, or the blood volume, and then this new parameter you saw. And this is just to show some examples from the literature, how people use this summary, some of the summary parameters. So instead of having to look, as you can see here, the parameters we talked about, the blood volume, the blood flow, this is this ratio between CTH and MTT, then you can opt to look, for instance, at the oxygen extraction fraction, so the portion of the oxygen that the tumor in this case is, or the tissue is actually able to extract. And this is an example of people who've been looking at this problem that many of you will know of, that after therapy of a tumor, then you might be interested in whether this if there's a new leakage turning up in your images and the patient has symptoms, is this the tumor regrowing, or is it simply an effect of the treatment that they have gotten? And this shows how it's quite easy to look at these images of the oxygen extraction fraction and get a summary of how do CVV, CTH, and blood flow combined affect the oxygen extraction. And notice here how there are little hot spots here. I'll come back to in this next image. I should notice that there was a small error here, so it says brain metastasis. It should say glioblastoma here, so apologies for that. The next image here is metastases, however, and again here the question is when there is leakage when we look at these patients at follow-up, is this regrowth of the metastasis, or is it due to progression, in this case, of a metastasis from lung cancer? And what actually I found interested in both of these reports, one from primary brain tumors, glioblastoma, in this case from metastasis, is that true progression, so where it was tumor or metastasis regrowth, there was elevated CVV, whereas the pseudoprogression in both cases appeared to be related to elevated oxygen extraction fraction on these maps. So again, I thought that was interesting that there seems to be this sort of additional signature of pseudoprogression in this case. Then I'll spend a little bit of time on talking about this vicious cycle that we saw before, namely how tumor growth causes hypoxia, which causes angiogenesis, which again or gives rise to these abnormal blood vessels over here that both may make hypoxia worse, but also may cause edema. And today we have therapies that can actually treat or can counteract angiogenesis, so anti-angiogenic therapy. And if you look at this confusing tumor vasculature, you can probably imagine that if you could say the anti-angiogenic therapy could, for instance, cut these shunting vessels here, then that might actually improve oxygenation in a tumor and make it respond better to other therapies, maybe not grow as much and so forth. Whereas if you accidentally cut some of the capillaries that actually function very well, then you may actually make things worse. So there's something to suggest that there might be something about, which tumors do you actually give this to, but also in which dose do you give it. And what I have down here is an example from people who actually measured the distribution of microvascular transit times in tumors. And then they saw what happened after they had treated a tumor with 2 different doses of anti-angiogenic therapy, as you see here. So what you see is that there are sort of different distributions of how, in this case, the contrast agent moves through this microcirculation. What we then did was that we applied the model you saw before, the one that allows us to translate or calculate oxygen extraction based on the distribution of transit times up here. And what we saw was that for one dose and in the same tumor, we actually saw a reduction in oxygenation, so measured as the oxygen uptake capacity we can calculate from our perfusion measurements. And the other there was a reduction here, but for a higher dose, there was actually an increase in oxygenation. So suggesting that how the microcirculation responds to anti-angiogenic therapy may actually depend on the dose that you give. And hence the idea of maybe because we're able to measure this and actually measure how the oxygenation responds to a given dose in an individual patient, we can do a better job of using these tools or using this drug. So there are some good people who then use software, this perfusion software, to actually measure in a cohort of patients what happens when patients receive. So what you saw just before, that was in rodent models of glioblastoma. This is real patient data. So people who received bevacizumab or Avastin, as it's called in some countries, and what they noticed was that if they measured the oxygen uptake before and after treatment in these patients, they saw a significant reduction. So that actually means that after the treatment, the oxygen, or the tumor in this case, had access to less oxygen because of the way that the drug had interacted with its microcirculation. And what you can see down here is quite interesting, because this is the CTH, so this parameter, or that becomes disturbed or is very high if there's a very chaotic microcirculation. And you can see how that parameter actually decreased after the treatment, suggesting that there is a normalization in the sense that the distribution of blood across the microcirculation becomes better, but in parallel, there are changes, and we'll see in a little while what those changes might be, so that oxygenation actually drops. And when they looked at their patient cohort, they could see that there was a higher risk of progression so recurrence of the tumor and of death in patients who had a high tumor oxygenation in the beginning, and had the greatest reduction of oxygenation is in response to the treatment. So this is important, of course, that it seems that there are, vascularized tumors who has a high, a microcirculation that provides them with a lot of oxygen, that are dangerous, if you will, but also that there is a reduction in tumor, that it's dangerous to have a large reduction of oxygenation of the tumor, consistent with what we saw up here, that hypoxia drives further tumor growth and the tumor becomes more aggressive in this vicious cycle. So let's dive a little bit more into this. So the same people actually had data from a larger study where they looked at a large cohort. So you can see the study down here. So in this case, Avastin was given or placebo was given in a large group of patients with recurrent glioblastoma. And you can see how something important down here, that if you compared contrast enhancing tumor in the ones who received the drug and the ones who didn't receive the drug, you can see how it decreased. So the contrast inhalation lesion went down on average in the ones who got the treatment, but it went up in the ones who didn't. So they got more leakage. And down here you see the degree of edema also went down, whereas it went up in the other patients. So it seems like that this part of the vicious cycle of the abnormal blood vessels, that works in a sense that you seem to remove some of these abnormal blood vessels that cause leakage, so contrast enhancement, and you also seem to reduce edema. And that's why it's a great drug for many patients, because they, of course, they may have less symptoms and have more time before their symptoms recur if the edema is less and leakage is less. However, what happened on the same time was what you see over here, is that the blood volume, so consistent with that, it takes out some blood vessels, blood volume went down. The blood flow also went down, and as we saw here, the net oxygenation went down. And this reduction in blood flow is probably one of the causes why this happens, and why this part, so the hypoxia, becomes worse, and that actually has a bad impact on tumor growth and the overall progression of the tumor. You can see how there were no effects over in the ones who didn't receive the therapy. And that is actually in line with the rather sad results of this large trial, namely that it does improve the progression-free survival, meaning that patients have a better quality of life, less symptoms before their tumor returns, but it does not sort of improve their overall survival. And so one can speculate, of course, that that's because it does by modifying blood vessels, it's like it takes out the blood vessels that are really bad because they cause leakage and edema, but somehow it also does something to the vessels that could keep the tumor oxygenated and therefore responding to other sorts of treatment. So just to summarize, you've learned that tumor oxygenation impacts the aggressiveness of a tumor. It impacts how they respond to treatment, whether it's radiation therapy, chemotherapy, or immunotherapy. Hypoxic tumors recur more quickly after treatment, and hypoxic tumors are associated with a poor prognosis. And what this next generation perfusion parameters provide us with is very specific in the sense that they address angiogenesis, so new blood vessels being formed. They also allow us to look at local blood supply, and important, this separate phenomenon, namely that the microcirculation, this shunting, that the fact that the tumor's microcirculation is not able to distribute oxygen very well, it measures that directly. And then you've seen how, rather than looking at all of these parameters, we can look at these compound parameters where this is turned into one parameter using a biophysical model that tells us what actually happened to oxygenation, or what is the oxygenation in a tumor. And the perspectives, of course, this is something that a lot of people are looking at right now. It certainly provides us with more information, and also information that potentially has diagnostic and prognostic information in individual tumors. And I know of many places and labs in the world where people are working on just that. Of course, I cannot help but think that maybe with these tools, we can also, with the experience we have now, for instance, with anti-angiogenic therapy, that we may actually be able to, think of in the future to try to use these tools to try to predict which tumors, respond favorably both to closing the blood-brain barrier or reducing leakage, but also to improving oxygenation. And then we can actually do measurements as we try to dose these therapies with our perfusion biomarkers. So with that, I want to thank you for being so attentive and also invite any questions that you might have. So thank you so much for listening.
That was fantastic, as usual, Professor Østergaard. Thank you so much. We do actually have a question that was put in the chat. Dear Leif, thank you so much for the amazing presentation. And this is from Chris. I actually had a few questions. In the equations used for the estimation of the oxygenation parameters, there is no variable included that takes the initial condition into account, presence of oxygen within tissue prior oxygen delivery. This means that the equations describe a start without any oxygen in the tissue. How relevant would it be to include such a baseline variable regarding to tissue oxygen concentration prior oxygen delivery? Would this be relevant at all? Or would this have only limited effects on the parameter estimations and would add the necessary complexities for robustly estimating the oxygenation parameters? That's part one. And then there's a part two, but I'll let you answer the first one.
Should we take part one? That's an excellent question, and thank you so much for raising this. So essentially, if we look at the equations and how we calculate oxygenation based on our perfusion parameters, then we essentially have to assume at least one parameter, and that is either the oxygen metabolism in the tissue, and that's one that we can sort of relatively safely assume, for instance, in normal brain, based on what it is in white matter, because that's very constant from person to person. But as you correctly point out, we don't really know that in a tumor, for instance, what that is, but we may be able to get sort of an idea from comparing with other brain regions. And then based on so we can either assume what a normal white matter oxygen metabolism is from the literature, and then based on that we can move the opposite direction and calculate what the oxygen tension in the tissue would have to be in order to support that oxygen metabolism. So that means that when we look at, and there's some people who use it the other way around, so they're interested in looking changes in oxygen tension as opposed to oxygen metabolism, but that is under that assumption, or that we do it assuming something about how oxygen tension behaves in normal brain. And as you point out here, the tumor microenvironment is so complex that we really can't do that. Then there's another, I think you may also allude to another thing in your question, namely that the kinetics, or the way that the flow diffusion equation now gets a little bit technical, but those who are think it's too nerdy, can just have a sip of water while I tell this. So when we describe how oxygen extracted by tissue, we use an equation that essentially assumes that oxygen disappears from the tissue once it gets outside the capillary, and that's not completely accurate. And so we've done comparisons actually where we take these perfusion algorithms and then compare them with the estimates we get with gold standard PET measurements, and it actually looks fairly good. But it is an assumption, and again, if we made the same kind of comparisons using or in brain tumors, I think it would look even more complicated. But thank you for that very observant question.
So the second half of the question was with respect to CMR02. Would this have similar with your kinetics? Because it says you mentioned that CMR02 also depends on tissue oxygen concentration, which is according to the Michaelis-Menten kinetics. This also shows that CMR02 is not linearly related to the tissue oxygen concentration, which is most likely reflected due to the limited capacity of mitochondria to use the available oxygen. So those are. Okay.
Sorry.
Oh no, he talks about the Fick principle. So I guess is this along the same type of what you were just speaking about?
Yes, it is, and they're very good. There's it refers a little bit to what we talked about before, namely that we don't exactly know what the oxygen tension is in the interstitium, and that of course is what affects the tumor cells. But there's also the binding of oxygen to hemoglobin is actually included in this equation, so that it takes into account what that is. But you also raise some other really important issues. One being, for instance, and we write a little bit about that in that paper you saw from 2013 about what happens to glucose at the same time, because in tumors, glucose is, has a slightly different distribution than oxygen, of course, because it diffuses in a different way, and it relies in some places on active transport, if you will. So that becomes a very important question, because when tumors run out of oxygen, they still spend a lot of glucose on anaerobic glycolysis, which makes the tissue quite acidic, and that relates both to the hemoglobin binding, but also that mitochondria in tumors and the surrounding tissue, they have to adapt a lot. And just as a really striking feature, then since we looked at this, it's been found out that tumor cells actually form connections to normal brain cells and steal their mitochondria. So it means that they actually make little nanotubes to surrounding cells to get functional mitochondria they can use for their own purposes. That was a long answer. Apologies.
Wonderful.
Thanks, Chris.
That is fantastic. Yes. Does anyone have any other questions? If not, Chris does have a slightly technical more question.
We love technical questions.
We do. We do. Go right ahead, Chris. For determination of tissue oxygen concentration, you use literature-derived Vmax values and considered CMR02 as 80% of Vmax. Subsequently, you determined KM and determines KM as a reasonable estimate as it led to an estimation of tissue oxygen concentration of 15 millimeter. However, neurology. Oh, I'm really off on my sorry. It's considered hypoxic, hence makes physicians very concerned if this was indeed the case. Wouldn't another estimate for tissue oxygen concentration have been a better estimate? And how does such a hypoxic state translate to the reliability of other oxygenation parameters that are generated as they are based under the same assumptions?
That's a very good point. So I think so essentially, when we started modeling how transit times they affect oxygenation in the brain, we did it in two different ways. One being the one that's in the Jespersen and Østergaard publication, and one in the Anglais paper, also in JCVF&M. And I think that's where the last estimate that you cite of oxygen tension that comes from, and that is the better model in many senses, in the sense that it sort of speaks of the right Michaelis-Menten kinetics and so forth. And so it also has many constraints, and that means that the oxygen tension you just mentioned of 15 millimeters of mercury, that is not very nice. So that would be hypoxic and cause inflammation and all sorts of problems in the tissue. So that's sort of a compromise we had to make, or a decision we had to make when we modeled it in a slightly different way, and that approach has all other shortcomings. I should say that the oxygen tension we use in the other model, so the model that's implemented in this software, the one that that's based on only on the flow diffusion equation that Sune Jespersen used, there we assume the normal oxygen tension to be 25 or 26 rather millimeters of mercury, which is a more healthy one in the sense that it's consistent with when blood is half desaturated in the brain and so forth. Then on top of that, I've gone to quite a few meetings on oxygen in the brain, and it's something that can always get people excited about, to what the real values are. Some believe that they're higher than 25 or 26 millimeters of mercury because they measure it with techniques that sort of sample a slightly bigger volume. So it's a very interesting topic, but you're completely right that you should be worried about 15 millimeters of mercury. And I'd love to discuss it more over a beer if we meet one day, Chris.
That is absolutely fascinating. Thank you. Chris, thank you for those wonderful questions too. That is fantastic. And he did say, thank you very much. Your answers really helped me in a lot of understanding. Me too.
If nothing else, thank you for being so appreciative and polite.
Does anybody else have any other questions? Tim Durham, if therapies were improved to cross the blood-brain barrier and better target the tumor in the brain, could these perfusion imaging parameters be used to monitor and improve treatment effect?
Yeah, that's actually what we are hoping. And I've spoken to colleagues in the US actually who have been contemplating to essentially do what we talked about a little bit in the end, to essentially give a test dose of an angiogenic therapy and see how the microcirculation responds, and then try to find a way where you have that, if there is an optimum to be found between getting microcirculation that's not so leaky, meaning that the edema pressure and doesn't give the patient so many symptoms, but while improving oxygenation more, because there are also ways of improving blood flow, which seems to be what is causing the hypoxia here. So it's kind of along those lines that it would be interesting to try to make these, where you don't use a one-size-fits-all dose of whatever therapy you are looking at, but try to optimize it towards oxygenation, because we know that that's really what makes tumors most sensitive to all of the treatments we have, whether it's radiation, chemotherapy, or immunotherapy.
And so thank you. He learned a lot from this webinar as well.
Thanks, Tim.
He's teaching so much, Professor Østergaard. It is the goal of these webinars. This is why we do these. Excellent. Do we have any other questions from the audience? Not at the moment. Well, Professor Østergaard, as always, it is an absolute pleasure to have you. Your webinars are phenomenal. People, as you can see, clearly learn so much from you. It is always an honor to have you.
Thank you so much.
Thank you. And if you did miss Professor Østergaard's last webinar that we had, it is available, like I said earlier, on the Cercare Medical YouTube channel. You can catch all of our past webinar recordings. We do have another one coming up next week, like I said earlier, with Professor Sebastian Swaz. We have more coming towards the end of the year as well. So always be on the lookout for the webinars that we post up on LinkedIn. Make sure you guys register. But thank you as always for joining us. And please, if you have any questions, don't ever hesitate to reach out on LinkedIn or to your local sales or CAS. Thank you so much.
Thank you for attending.